Deflating and inflating a calf tracheostomy tube. Definition: a calf tracheostomy tube compounds the nursing care requirements of the patient in acute respiratory failure. A calf is so designed that when it is properly inflated, it forms a seal between the tracheostomy tube and the trachea, preventing air from entering around the tube. Critical elements for calf deflation: maintain asepsis when suctioning. Suction the oropharyngeal cavity adequately before calf deflation. Withdraw the correct amount of air when the client inhales and while providing a positive pressure breath. If calf reflex is stimulated, suction the lower airway. For calf inflation, inflate the calf on inhalation. Follow the minimal leak technique. Make sure that the calf pressure inserted does not exceed 15 to 20 mmHg or 25 cm. Clamp the inflation tube if required. Document the exact amount of air used to inflate the calf. Process: during the first 12 hours after a tracheostomy, when the client is being ventilated or receiving IPB therapy to prevent leakage, when the client is eating or receiving oral medications, when the client is comatose to prevent aspirations for oropharyngeal secretions. Equipment needed for suctioning the oropharyngeal cavity: 5 to 10 ml syringe, stethoscope, rubber tube, hemostat, manual resuscitator or ambu-bag, manometer specifically designed to measure calf pressure if available, sterile 3-way stopcock optional.
A tracheostomy is a surgical opening in the windpipe or trachea. A tube is placed in the opening, thus the air goes in and out of the tube rather than through the nose, mouth, and throat. Because the nose and throat are bypassed, the air does not get filtered or humidified. This leads to mucus. Here's a picture of how the tracheostomy tube fits in the trachea. A patient would need a tracheostomy for 3 reasons. 1, to bypass an obstructed airway. 2, to clean and remove secretions from the airway. And 3, to effectively and safely deliver oxygen to the lungs. The parts of a trach include the connector, the inner and outer cannula, the neck flange, the cuff, inflation line, cuff port, Luer valve, and obturator. The connector is the outermost portion of the tracheostomy tube. Ventilator tubing, a manual resuscitation bag, or a speaking valve may be connected to the connector. Here's a picture of humidified oxygen being administered through the tracheostomy tube. The neck flange has holes on either side for securing neckties. These neckties will keep the tracheostomy tube in place. The external cannula is the tube that is inserted into your windpipe. It stays there all the time and may have another part called the internal cannula that slides inside of it. The internal cannula is the tube that fits inside your outer tracheostomy tube. It is removed for cleaning or replacement. Lastly is the obturator. It is used as a guide to insert the tracheostomy tube. The inflation line is thin plastic tubing that carries air to and from the cuff. The cuff port is a small plastic balloon-like component on the end of the inflation line. The cuff port shows if the cuff is inflated. The Luer valve is where the syringe is connected to inflate or deflate the cuff. The cuff or the balloon is on the end of the tracheostomy tube. When inflated, it forms a seal against the wall of your windpipe. This stops the airflow through your mouth and nose so that you breathe through the tracheostomy tube. When the cuff is inflated, the patient will be unable to speak. Here's an illustration of how the cuff works. When the cuff is inflated, the patient will only be breathing through the tracheostomy tube. When the cuff is deflated, the patient will be able to breathe through their nose, mouth, and throat. As a nurse, you need to ensure that if the balloon is inflated, the tracheostomy tube is not capped. Otherwise, the patient will have no airway.
If a tracheostomy tube lumen becomes blocked, or the tube itself becomes displaced, then the cuff can hamper attempts to oxygenate via the nose and mouth. Deflating the cuff, as shown here via the pilot balloon, can allow gas to move via the nose and mouth, past the obstructed or blocked tracheostomy tube. Once you've deflated the cuff, reassess by look, listening and feeling at the mouth and tracheostomy. A water circuit or capnography can aid this assessment.